you for joining us to our international rounds. It's my great pleasure to introduce Dr. Jill Steiner, who is going to talk today about, I think, a very important topic that we commonly forgotten, as palliative care and resilience in adult congenital heart disease. So Jill is an assistant professor in the Division of Cardiology in the University of Washington. And Jill, thank you very much for agreeing to give the talk and to cover this important topic. So the floor is yours.
Wonderful. Thank you so much. Good morning, and thank you everyone for being here today. I'm excited to talk about incorporating palliative care and resilience into the care of our adult congenital heart disease patients as a way to help them live well despite illness. These are my learning objectives for the talk. I hope to first establish the value of palliative care in ACHD, then define resilience and its potential application in ACHD, and ultimately demonstrate the significance of palliative care and resilience research in ACHD. I certainly don't have to tell this group about the extreme amount of heterogeneity that exists in our patient population in terms of anatomy, hemodynamic impact and disability, and life expectancy. Some of our patients struggle with heart failure and everything that comes with it, and some of them are professional athletes. In most cases, people with the most severe anatomic disease also experience the most significant limitations, but that's not always the case. And it's often hard to tell just by looking at someone how bad their underlying heart disease might be. One of the major challenges in managing ACHD is recognizing and addressing its impact on quality of life. Now, at this point that we've gotten them living far into adult life and actually some reaching geriatric age. Many factors affect quality of life in this population, most obviously physical and cognitive limitations, but also psychosocial issues like mental health, altered social relationships, and low self-esteem, as well as more systemic things like prognostic uncertainty and problems with the medical system. This brings up the point that ACHD care needs to be about more than just getting people to live longer, and that a focus on quality of life now is just as, if not more important than quantity. Many of these heavily psychosocial issues are just starting to be recognized in ACHD and are quickly changing the landscape for what is considered good care. One of the ways we can support better quality of life in ACHD is to utilize the principles of palliative care. Palliative care is a type of medical care that focuses on supporting patients with serious illness and their caregivers. The core tenets of palliative care are promoting communication, such as about patients' disease processes, their values and future goals of care, providing in particular emotional and spiritual support, symptom management, and ultimately improving quality of life. Palliative care is appropriate at any age, any stage of a serious, life-limiting, or life-threatening disease, helping people live the best that they can for as long as they can. Palliative care primarily benefits patients, but it is also intended to support their families, the healthcare system, and society. Palliative care provides an extra layer of support for multiple dimensions of the patient experience. In the physical domain, palliative care is symptom management of fatigue, dyspnea, and often symptoms beyond what are considered normal or typical for that disease, like pain or anorexia in heart disease. In the emotional domain, it's support for psychological distress, managing anxiety and depression, and facilitating effective coping. In the social domain, it's addressing caregivers' needs, supporting relationships, and helping address financial concerns. In the spiritual domain, it's helping patients maintain hope, faith, and find some meaning in their illness experience. And in the informational domain, palliative care can address prognosis, facilitate illness understanding, and planning for the future. In the United States, palliative care can be practiced by any clinician with interest and experience in this area. This is called primary palliative care and involves the basic management of symptoms, discussions about the future, and emotional support. Secondary or specialist palliative care is typically provided by folks who've had advanced training in palliative care. These can be physicians, advanced practice clinicians, social workers, nurses, chaplains, etc. And secondary palliative care involves more complex symptom management, such as of refractory symptoms and working through complex care coordination needs. In heart failure, we think of palliative care, which is represented by the blue coloring in this figure here, as an added layer of support, which is there the whole time and increases in times of acute worsening or disease progression. The ups and downs of heart failure management, rather than any smooth trajectory, make palliative care implementation more challenging than, for instance, in cancer. And so when it was introduced in cancer initially decades ago, palliative care was what you did when someone had no further options for life prolonging care, when it was time to move to hospice. But since then, palliative care has evolved into more of a longitudinal process, occurring alongside life prolonging care and ramping up as comfort becomes the primary focus of care. To some extent, that figure applies to patients with ACHD, but they'll also experience ups and downs, and ultimately heart failure affects the majority. But adults with congenital heart disease are not your typical acquired adult heart failure patients. They're often much younger and in a unique stage of life. They're exploring autonomy and responsibility for their health. And often they come with this feeling of having already beaten the odds, sometimes projecting feelings of invincibility. This can be exacerbated by the existence of general cohorts of patients, such that there's often no comparable patient who's come before, which can make prognostication very difficult. And taken together, clinicians, even at exceptional specialty centers, and especially when it comes to making decisions about therapies for advanced heart disease, clinicians are not necessarily familiar with or comfortable caring for this group. Our ACHD care guidelines promote the inclusion of palliative care. The latest ACC-AHA and ESC guidelines each contain about a half-page section on this issue, but they don't offer much guidance on when or specifically how to do this. And that's largely because there has not been a lot of scientific evidence created for the use of palliative care in ACHD. And the ACHA and ACC say something like the discussion of end-of-life issues and advanced directives can be beneficial for patients with ACHD or their surrogates. They give this a fairly high rating, 2A, but it's not based in much research. And the ESC says timely discussion of advanced care planning is a critical component of patient-centered comprehensive care, but that what that looks like depends on the patient's physical and psychological health and preferences. And they don't give a level of recommendation for this. A recent position paper from the ESC displays palliative care integration as a heat map, which you can see here going from green to purple in the background of this figure. The authors recommend starting to talk about future health as part of all visits, gradually achieving components of advanced care planning and ramping up as disease progresses. This requires those conversations to be realistic and sometimes frank, avoiding an overly rosy but also an overly gloomy representation of what the future might look like. We define advanced care planning as the process of evaluating one's goals, values, and preferences about future health care and communicating those with surrogates in case the patient is unable to communicate their wishes. Examples of products of advanced care planning are included on the right side of the figure, formally naming a healthcare representative and creating an advanced directive in which these preferences may be outlined. So what do studies tell us about about palliative care in adult congenital heart disease? We know most about advanced care planning. Initial group of studies conducted there in Toronto in the early 2000s focused on advanced care planning and really laid the groundwork for everything that we know about palliative care in ACHD and what's been done since then to learn more. In this survey of ACHD outpatients, 87% thought it was important for someone to know their wishes if they became too sick to communicate. However, 56% of them had never heard of advanced directives, and 77% had never written down their wishes or thoughts about future healthcare at all. Only 18% of them had appointed a power of attorney, and there was a limited self-reported ability of cardiologists to have advanced care planning and end-of-life discussions with their patients. A major barrier identified in this study was lack of clarity as to when and how to start advanced care planning discussions. There was also a huge disconnect between patient and clinician or provider perspectives on advanced care planning. About 50% of local providers reported having discussed end of life with their patients at least once, but only 1% of those patients reported discussing end of life with those same providers. Less than half of providers reported a preference to initiate end-of-life discussions when patients were healthy, but with an increased likelihood of doing so as patients' disease got worse. However, 62% of patients preferred engaging in these discussions when they were healthy, regardless of their disease severity, and even if they had a greater than 10-year life expectancy. Patients also wanted their providers to initiate end-of-life discussions, thinking that they would do so when it was time to start thinking about these things. Finally, in the only inpatient study, and look at whether this type of care mattered, I love this title, end-of-life discussions were documented for only 10% of patients who died, 6% prior to the admission where the death occurred, and 4% 4% during the admission. Eventually, discussions were documented with 41% of surrogates, but for the most part, those conversations occurred in the setting of futility, on average 2 days prior to the patient's death. And the kicker for me here is that all of these deaths were expected. All the patients in the study were reported to be highly symptomatic, had previously had multiple heart-related admissions, and 42% had already undergone transplant evaluations. But only 10% had documented end-of-life discussions. As to whether or not these discussions mattered, those who did have documentation of an end-of-life discussion in the chart were less likely to undergo aggressive resuscitation at end of life. And even though very few patients were referred for specialty palliative care, none of those who were referred died under attempted resuscitation. So maybe some indication that palliative care could affect outcomes, even though discussions rarely occurred ahead of time. There have not been any studies yet of palliative care as related to patient-reported outcomes and no clinical trials, but I know we're working on that. To better understand why this might be the state of palliative care in ACHD, it was important to first learn more about the palliative care needs of our ACHD patients. In examining the last month of life for patients who died with ACHD, we demonstrated high healthcare resource utilization. 40% of patients were hospitalized, an additional almost 40% had an ICU admission, and 64% died in the hospital. Patients with ACHD were less likely to have ICU admissions than patients with acquired heart failure, which we thought might reflect lower use of advanced heart failure therapies, either related to lack of candidacy or lack of opportunity. But when we compared these patients to those with cancer, patients with ACHD were significantly more likely to have inpatient and ICU admissions, as well as more likely to die in the hospital. And we thought these differences might be driven by variations in the use of palliative care between groups. Finally, we found that 41% of patients with ACHD who died had some documentation of advanced care planning in the electronic health record. This was significantly higher than patients with cancer, surprisingly, and comparable to patients with heart failure. But we couldn't tell when that documentation was created, so it could have happened just at the very end and with surrogates, as in the prior study. Data from this Belgian registry very recently corroborated this concern for higher healthcare utilization now in the last year and month of life, and with even more striking numbers. 87% of patients in this study were hospitalized in their last year of life, and 78 had a separate emergency department visit. An additional important finding in this study is that this very low level of palliative care specialist involvement in 17% of cases overall, and only 4% of the patients with ACHD who died of a cardiovascular cause had palliative care as part of their end-of-life care. Right around the time of that first group of studies on advanced care planning, this survey of outpatients at Penn reported a similarly low prevalence of advanced care planning, and also that patients were interested in learning more about life expectancy and advanced care planning. But unlike the prior studies, this was reported by patients with lower ACHD complexity and those with higher levels of anxiety, which we know is a common comorbidity in ACHD. So wondering if there might be something more to what type and how bad ACHD needs to be before we start seeing this interest arise. And additionally, this study suggested advanced care planning discussions should start around age 18, but that they could start earlier depending on the readiness of the adult to meaningfully engage. And this is likely where the guidelines recommendation comes from. Building on this, we designed an outpatient survey asking patients about advanced care planning and palliative care, because up until this point, we only knew a little bit about advanced care planning. About half had each at least one hospitalization in the last year. Some had, about half had some ACHD related physical limitation and had worries about their heart condition. Like the other studies, we found a similarly low prevalence of people who had previously engaged in advanced care planning, 14% and 29%. However, participants were very willing to discuss their care preferences, participate in advanced care planning, and even speak to a palliative care specialist if their ACHD doctor recommended it. Folks who were married or who anticipated having shorter lifespans were even more willing. We've also identified some key barriers and facilitators for participating in palliative care and advanced care planning, and many of these are in line with prior studies. Top reasons for engaging are worrying about quality of life and being a burden on friends and family. Participants who had prior experiences with serious illness, either themselves or with a friend or family member, were more interested. But on the other hand, reasons against engaging in palliative care and ACP, advanced care planning, were not feeling sick enough, not knowing which doctor would care for them, so who to talk to about this, not being ready to discuss these issues, and worries that their preferences might change in the future or depending on the situation. To learn more about what was driving these facilitators and barriers and why, if patients were willing, why palliative care and advanced care planning weren't happening, we conducted a qualitative interview study. 4 primary themes arose from the thematic analysis of these interview data. The first theme was using knowledge, the importance of using knowledge as a tool to combat future prognostic uncertainty. The second was unfamiliarity with and limited prior exposure to palliative care and advanced care planning. The third was palliative care and advanced care planning are good ideas, but they don't feel personally relevant to otherwise young, healthy people. And that the importance of tailoring timing and presentation and of advanced care planning discussions really deserved some attention. Here is an exemplary quote for the second theme about lack of palliative care knowledge. "It sounds scary, and I would be scared if I hear that, because that's like hearing my doctor give up on me." And that's exactly what many of our patients think immediately when we say the words palliative care, and something we need to work to change. Here's an exemplary quote for the last theme about tailoring materials. "If you give them something that has a gray-haired person on the front, I think it implies that, well, these are things to think about, but I don't really need to do it right now." And we know that that certainly may not always be the case. We also learned that there's probably no best time to start advanced care planning and palliative care discussions, or at least that this conversation is very nuanced. We know previously the median age for recommendation was 18, but we heard everything from bring it up to when they're diagnosed to wait until age 65 when they start having other problems. Often these recommendations depended on what else was going on with the patient's health and how mature or emotionally ready the patient might be to engage in these discussions. This study really showed us a need for thoughtful and tailored patient education about these issues, but also that there was a need for something that felt useful to them now. And I'll come back to that idea in just a minute. The only population level study on this topic that I'm aware of from within the US comes from the CH Strong registry. This study also found a very low prevalence of advanced directives, even in patients with heart failure. And this table shows who was most likely to have them. As you can see, these patients are more likely to have touch points with or access to healthcare, which I think points to the importance of clinicians in providing palliative care, or at least raising it as a topic of conversation. So how do ACHD clinicians feel about palliative care? In a survey of clinicians attending our International ACHD Symposium a few years ago, even though the majority would initiate advanced care planning and end-of-life discussions while patients were healthy, the severity of their disease played a role, which you can see by the larger sections of the pie chart here. And still almost 1/4 would wait until some serious complication arose. Participants in this study identified a number of barriers to initiating these discussions. First, that it might be too early to prognosticate. We don't know what's going to happen. We don't want to take away hope too early. There were also concerns about family and support, and actually patients having young children was suggested as a reason not to discuss end of life, and I would actually argue the opposite for that one. The third barrier was inaccurate patient knowledge or expectations, which made these conversations feel too onerous. As part of this survey, we presented fictional case presentations and asked clinicians about their comfort in managing associated symptoms. The colors here are a heat map, a cold heat map, where greater comfort is represented by dark blue and less comfort by lighter blues and gray. Not surprisingly, clinicians were relatively comfortable managing fluid retention and dyspnea for their ACHD patients with advanced disease, but they were less comfortable with psychosocial issues like anxiety, depression, and patient expectations surrounding transplant candidacy. For 3 of the cases, we asked about another issue, which were ICD deactivation, pain management, and family disagreement. And you can see the striking lack of comfort, high level of discomfort in managing these concerns. Interestingly, clinicians were about as comfortable discussing prognosis as managing dyspnea, right? We do this all the time, even if it feels bad. And in almost all cases, clinicians thought advance directives were important for these fictional patients. And this one's importance, not comfort with help creating one. But only rarely would they initiate advanced care planning themselves. And even less commonly would they refer to specialty palliative care. So this left us asking, then who's going to do it? And remember, the prior study showed us that patients want and expect their clinicians, especially their ACHD clinicians, to initiate these discussions when it's time. So how do we use this information? And more importantly, how do we use it to improve patient care? Because ultimately, that's what we're here to do. First, there's so much more we need to learn about how palliative care might benefit our patients, and even how it might not. But with what we do know on the clinician side, it's education and engagement, which I won't specifically address today. But I would like to talk about one approach we're taking to use palliative care to support patients with ACHD, and that is resilience. We know that having ACHD impacts many aspects of our patients' lives. In our qualitative study, even though we asked our patients about experiences with palliative care and advanced care planning, almost everyone talked spontaneously about these long-term impacts. They also voiced concerns about having a lack of skills to cope with their chronic illness and to manage disease uncertainty. So we started thinking more about how to address these concerns, which seem to center on quality of life. So still falling under that palliative care umbrella, but different than the idea of advanced care planning for a future that felt too far away. Resilience is one aspect of palliative care, which is often called upon to empower patients as they navigate serious illness. Resilience is recognized in many fields and used in a variety of ways. But in health psychology, one definition is the process of harnessing personal resources to sustain physical and emotional well-being in the face of stress. Resilience is often referred to as bouncing back from a challenge or someone having grit. A person's resilience at baseline is somewhat inherent, but it can be strengthened and developed both through life experience and targeted education. A person goes through 3 overlapping phases of resilience when facing a challenge. The first and perhaps most instinctual is getting through whatever the challenge is. Having survived the initial exposure, the person can begin to harness resources within and around them to begin to move forward. And eventually, hopefully, they're able to look back and learn from the experience, and through this process, resilience grows. Areas of overlap between these phases, representing the process of building resilience, are assessing ourselves, appraising the situation, and building identity and purpose. Harnessing resources, that part between getting through and looking back, means calling on the things a person has within or around them for help. These resilience resources can seem to be universal and generally fall into one of 3 categories or buckets. The first bucket is internal resources, things like personality traits or learned skills. Examples are setting goals and managing stress. The second is external resources, social interactions, things like support and who provides it. And the third is existential, for example, spirituality and finding meaning in the experience. And to what extent each of these buckets works for an individual varies depending on the situation and on one's individual needs, as well as on cultural and societal influences. Going back for a second to the factors we know affect quality of life in ACHD, I would be remiss not to mention sense of coherence, a concept adjacent to resilience. Sense of coherence comes from Antonovsky's salutogenic theory about promoting health and well-being rather than solely recognizing and reacting to disease. People who have a strong sense of coherence view their lives as comprehensible, manageable, and meaningful, as informed by life events and the perceived resources available to help them process those experiences. This in turn promotes effective coping, which influences health, and we can measure that using clinical and patient-reported outcomes. For ACHD, sense of coherence was suggested in 2006 as a way to support psychosocial health. Combating uncertainty with education can promote comprehensibility. So it was suggested that parents and clinicians prepare the child with congenital heart disease to deal with their disease realistically as an adult. Finding adequate balance between stressors and perceived resources is a way to promote manageability. So it was suggested that parents and clinicians provide the person with congenital heart disease specific support from the trauma of living with this disease. And finding ways to help life make sense and having the motivation to do so promotes meaningfulness. So it was suggested that the patient with congenital heart disease be invited from an early age to participate in shaping their future, and that steps should be taken along the way to teach appreciation for the little things and address any existential feelings that arise. Sense of coherence has been found to be associated with quality of life in ACHD, as I've said, but also with perceived physical and emotional health. And degree of perceived personal control over a situation emerged as an umbrella concept that separated people with strong versus weak sense of coherence. Sense of coherence has been found to be worse in people of younger age, lower education, people who are unemployed, and those who are non-partnered. Perhaps not surprising, since these characteristics tend to track with lower quality of life and a lower sense of control. Interestingly, though, sense of coherence was worse for people with lower NYHA class, better function, and simple or minor ACHD. And the suggested reason was perhaps these people have not faced as much adversity related to their heart disease, and therefore haven't had as much need to rise to the occasion. And the takeaway from these studies is that sense of coherence may help identify patients at risk for poor health outcomes, and they may facilitate timely referral for psychosocial care. So doesn't that sound like resilience? It's not quite the same thing, but it's very similar. Resilience and sense of coherence do overlap, but they are distinct concepts, and they both contribute to the development of good health. Resilience describes the process of what facilitates people bouncing back after a challenge, and sense of coherence describes the outlook that facilitates people moving forward in terms of their mental health. Where they overlap is that both act as mediators between trauma and the person's subsequent emotional health, specifically the development of depressive and anxiety disorders, or DAD, in this diagram. Sense of coherence has also been proposed as a mechanism by which resilience is developed and as one of those internal resilience resources. Returning to the concept of resilience then, only few studies have examined the applicability of resilience in ACHD. In these two cross-sectional survey studies of adults, patients with ACHD had comparable or higher resilience versus similarly aged peers without congenital heart disease. And congenital heart disease severity was negatively associated with resilience only in patients with poor functional status. Resilience was associated with higher levels of religiosity, so maybe reflecting that existential bucket, and with health-related quality of life. And these papers suggested that since patients with greater resilience had better health-related quality of life, it may be beneficial to implement interventions to foster resilience. So folks have started to think about resilience as an intervention target in ACHD, but we have not yet seen interventional studies specific to resilience. Two studies reflected here used behavioral interventions to decrease psychological distress and increase coping, but they do not go as far as assessing effects on resilience. And a third study reported that patients who participated in a single 3-hour intervention had higher post-test resilience scores, but there was no discussion as to mechanism or whether this was truly a change in resilience. Another thing to think about for all three of these studies is that they were all delivered in group format. And given the somewhat private nature of vulnerability, stigma, and distress, some patients might prefer one-on-one interventions. And like I said, none of these studies, nor the observational ones that came before, examine the underlying mechanisms or manifestations of resilience in ACHD. So what are we actually targeting? And how can we ensure that we can move the needle with an intervention? It's exactly those mechanisms and manifestations which my research team and I are interested in. And so using this concept map from Folkman and Greer, you can see how resilience resources, I hope, contribute to situational appraisal, influence coping, and ultimately determine the outcome of whether the person experiences distress versus positive or neutral emotions. And based on this, we designed a series of studies to further examine the links between resilience and key patient-centered psychosocial outcomes like quality of life. In a group of patients with moderate or complex adult congenital heart disease, we found mediocre self-reported resilience. The score of 29 on the CD-RISC-10 tool is on the cusp of the lowest quartile and below the median score of 32 in a random national sample of US adults. However, this is comparable to scores for groups of students internationally and some chronic illness populations like HIV positive women and people with cancer. Resilience was higher in patients who were married or who had a greater than high school education, and lower, interestingly, in patients who had complex congenital heart disease. It was stable over a 3-month period, and higher resilience was associated with better quality of life. We did not see any association for physiologic class, psychological distress, or self-efficacy. Excuse me. In trying to understand some of the underlying mechanisms, in qualitative interviews, we asked about familiarity with resilience and how it may be attributed to the way they manage their ACHD. Just over half were able to share their own definitions of resilience. And this group generally had more severe ACHD by anatomy and physiology, private insurance, and higher education than participants who could not. They associated resilience with pushing forward despite having ACHD and not letting ACHD stop them from living their lives. My personal favorites are realistic with a twist of optimism and this quote about mosaics. Participants who were reluctant or unable to provide a definition tended to describe more recent or current health challenges and generally provided fewer examples of ways that they managed or coped with having their ACHD. Resilience was generally thought of as a positive concept, but a few people did mention that being called resilient over and over could feel invalidating, especially if it came across as negating of their painful experiences. And not everyone felt resilient, even if they described resilient behavior. Like this person who said, if people look from the outside, I look resilient. But on the inside, if people look behind the curtain, the Wizard of Oz, there's a little man, I'm not that resilient. Although patients infrequently used the word resilient or resilience unless prompted, they described developing and using a variety of those resilience resources that I mentioned before across all 3 buckets. The described resources were similar to other chronic disease populations. Positivity, goal setting, and self-directed activities like meditation or exercise were prominently described internal resources. Support from family, friends, and community were key to successfully managing ACHD-related stress. And finding purpose, gratitude, and contributing to one's own health, or at least the feeling that they were doing something to help the situation, were common existential resources. We also found that some descriptions straddled buckets. For example, shown in purple here, red and blue, constructively reframing a negative emotion reflected internal and existential resources. And interactions with participants' children often provided purpose and meaning. Lots of people said something like, my kids definitely help me keep going. I definitely try to do the best for them. In thinking about how resilience influences coping, the majority of participants described secondary control coping styles. This entails adjusting one's hopes and expectations to align with reality, in contrast to primary control coping, in which the person makes an attempt to alter the stressor itself. This is not unexpected, as health events and the progression of ACHD are rarely alterable by the patient. Most participants had a first-line set of coping strategies that they developed with time and experience. Some were positive, some were negative, some were effective, some weren't, but they were there. And while many patients had backup strategies, it was difficult to switch to them. For example, restrictions and closures early in the COVID pandemic forced patients to change the way that they coped with ACHD-related stress. Being prohibited from exercising outside the home and the loss of external social support related to isolation practices in particular induced substantial anxiety and psychological distress. With this information about how patients experience and use resilience in managing their ACHD, patients and clinicians can better engage in discussions about psychosocial well-being and planning for the future. In research, this information can be used to develop or tailor mental health interventions to the specific needs of patients with ACHD. So right now, we're in the process of pilot testing a resilience-building intervention for our patients. PRISM, the Promoting Resilience and Stress Management intervention, teaches skills like meditation, setting goals, and finding meaning, in which patients can call on these skills in times of health-related stress. It also offers an introduction to planning for the future and thinking about one's values and care preferences. PRISM is administered one-on-one in coaching sessions with interim app support, and it has been shown to improve quality of life and lower psychological distress in other young adult and chronic illness populations. So hopefully it will prove a useful tool in ACHD as well. I look forward to sharing additional information as this field continues to grow. Today, I hope that I've demonstrated that quality of life is an important focus in ACHD care, at least equally as important as helping patients live longer. I also hope that I've demonstrated the value of incorporating palliative care into ACHD care to support their serious illness needs. And I hope I've given you a sense that resilience shows some promise as an intervenable method of supporting quality of life and other psychosocial concerns in ACHD. Thank you for your attention this morning. I have to call out Dr. Kovacs as someone who's helped me very much along the way, and I will stop there and take questions.
Thank you very much, Jill, for an excellent